Our next speaker is Dr. Tarjani Dave. She's a consultant at L.V. Prasad Eye Institute in Hyderabad, and she has been, let's say, a colleague, but has, I think, surpassed all of us now, and her presentations are something that I think all of us really look forward to, especially me.
Thank you, Savri. So from being Savri's student to here, it's a very, very good morning to hear that. All right, so I'm talking to you about red flags in oculoplasty on two specific conditions. One is thyroid eye disease, and second is invasive fungal sinusitis. So I'm going to speak about certain issues you see in both these conditions, which, like Savri mentioned, should raise a flag in your mind and might help you manage these patients in a much better way than you would otherwise have. So let's start with thyroid eye disease. We all know it has a very starey appearance. This is one classic patient of thyroid eye disease with a very congested orbit, and you can see that there's some amount of inflammation in both the eyes with this massive lower eyelid retraction on both the sides. You can see the prominence of the brow fat on both the sides, all of which are telltale signs of thyroid eye disease. This patient has been treated with steroids, and once you've done that, you see some amount of reduction in inflammation. So this is one of the classic presentations of an active thyroid eye disease. But what about this? So there's proptosis on the left side, which is very obvious, very, very massive proptosis. And he is actually a 53-year-old gentleman who's had this proptosis since 2007 and is stable. He's had sequential scans, again, which have been stable. And actually, these scans have been reported as him having a vascular malformation. So take a look at this. Clinical signs were very much like a thyroid eye disease, but look at the scan. It's very atypical. You don't see this kind of, shadows. You do see an enlarged superior rectus, probably a little enlargement of the medial rectus, but look at all these intraconal shadows. Very weird sort of a thing. And typically you see tent and belly both involved. So we thought probably it's a IOID and not a thyroid eye disease, and it might be good to consider a biopsy. So we opened him up, we did a biopsy in the same sitting. We also attempted a sclerotherapy because there was nothing to lose, and he'd already reported as a patient who has a vascular malformation. So we injected some bleo, we harvested some tissue. The tissue only demonstrated fibrofatty tissue, and we did multiple biopsies from multiple quadrants of the orbit, all of which demonstrated only fibrofatty tissue. So again, we were at a complete loss of what this really is. But what magically happened after the sclerotherapy is some amount of proptosis did reduce. His inflammation went down. We kept him under observation. He had some amount of residual proptosis, and he was very concerned with his appearance. So what exactly do you do in this kind of a situation? You can't go ahead and biopsy all this or remove all these tissues because they're so diffuse. You really can't do a good job there. So we went ahead and we did a decompression for him. So this actually, in my opinion, was a patient who had some amount of a vascular malformation in the orbit with an overlay of thyroid eye disease, and he had nothing else systemically like a deranged thyroid function test or any of the antibodies present, but just had this stable proptosis for some amount of time. Biopsy did not give us a clue. Eventually he remained rehabilitated for over 2 years of follow-up after the decompression as well. So as of now he's stable, but you do see these kind of cases where you are sort of left in the middle and you don't know where which direction to progress in. Just go by the clinical features and treat those clinical features. So I put this slide up to show you that if you see any patient with thyroid eye disease, you tend to see some amount of retraction of the eyelids. It could be the upper as well as the lower eyelid, or predominantly the lower eyelids, just a little bit of inferior scleral show. Any of those kind of features is what rings a bell about thyroid eye disease. But as has already been spoken in this course earlier by Savri as well as Dr. Rashmin Gandhi, ptosis is also a feature of thyroid eye disease. This is a lady who has bilateral aponeurotic ptosis along with proptosis. She has a systemic history of thyroid abnormality. These are her scans. You can see her enlarged muscles, and you see the eyeballs. They are practically, completely proptosed. and along with this proptosis, she also has a ptosis. So the largest component of ptosis in thyroid eye disease is actually the aponeurotic ptosis, where the aponeurosis probably stretches out or disinserts from the tarsus. But you also have a subgroup of patients with thyroid eye disease. Now, this is another lady. She has this temporal flare. She has a systemic thyroid abnormality who was kept under follow-up. And look at what happens 3 months later. She's come with drooping of both the eyelids. And when you do an eyes test, like Akshay so nicely demonstrated in his video, immediately you see an improvement in the ptosis. So this is myasthenia gravis associated with thyroid eye disease. It's been spoken so frequently in this course, and so many of us have seen ptosis due to myasthenia in patients with thyroid. But if you look at the literature, then that percentage is around 5% of patients with thyroid eye disease who develop ptosis. So that's another sign that you should keep in mind. These are not patients you want to operate upon. And the third cause of ptosis in thyroid eye disease, probably the most important one, is compression at the apex. So this is a lady with photographs taken only 3 days apart. She has thyroid eye disease with a compromised cornea and ocular surface. And when you look at her 3 days later, she's come with ptosis. It's not just the eyelid inflammation. You see the inflammation here as well. But despite that inflammation, she has a progression in her ptosis. So what should you do? You should image. Why do you need to image? These are the patients who are actually developing compression at the apex. So that compression is affecting the third nerve, which is worsening the ptosis. It's not only the edema in the eyelid which is worsening the ptosis. In a patient who has corneal involvement, looking for dysthyroid optic neuropathy becomes difficult because vision and color vision are clues that you will not have. But scans will tell you that yes, there is compression happening at the apex, and we decompressed her medial walls, made the medial rectus move away from the optic nerve, and this is a clinical picture post-decompression. While the inflammation takes time to resolve, you can see that the ptosis has immediately sort of resolved. The second condition I wanted to talk about was fungal sinusitis, fungal cellulitis. So these are pictures of patients with cellulitis, some typical, some atypical, but essentially you would see a very inflamed red hot orbit in most of these patients who have cellulitis. But look at this. It's a quiet eye. You have a little bit of ptosis. This patient is post-COVID, 27-year-old, de novo diabetic, following steroid treatment given during COVID because he had a severity score of 12, and he develops diplopia. That's his only complaint, 3 weeks after recovering from COVID-19. If you look at him, he has restricted motility of the right eye outwards. So obviously you're wondering that he's developing some kind of a nerve paralysis, but this can be a big masquerade. We went ahead and imaged him because we were all in that heat of post-COVID mucormycosis, and imaging intuitively would come to mind. And when we did that, you see actually that his medial orbit and inferior orbit are involved. He had to undergo sinus debridement. This was a patient who actually had mucormycosis. So just a nerve paralysis, as the presenting sign of mucormycosis. So that's a red flag. You're better off picking the patient earlier and treating him faster. The other thing as far as cellulitis is concerned, and which I have learned from personal experience, is whenever you see this kind of maceration of skin, ulcerated skin, those are cases where you're more likely to get a fungal disease. And these are cases where I'd go all guns blazing, I'd give a PCR for fungus and do the entire diagnostic battery of tests that I have to make sure that this is a fungal disease. We did all of that. We did not find any fungus. We treated the patients with antibiotics. He did not respond. He had a sinus involvement as well. So I sent him to an ENT surgeon to debride the sinus. And once the sinuses were debrided, that actually picked up fungal filaments. So the orbital or the eyelid tissues did not show us any fungus. The sinus showed us fungus. We treated him with amphotericin B as well as itraconazole as a maintenance therapy. And this is him couple of months later with complete resolution of that necrotic eyelid mass. The other situation is something like this, where this lady presents with just a 15-day history of blurred vision in the left eye. But if you look at her, this kind of hypoglobus is difficult to come up over 15 days, and there are these irregular nodules everywhere around the eye. We couldn't figure out what exactly we're dealing with, so we ordered for a scan, and this is how the scan looks. So your first thought would be that this is some form of a tumor, possibly a benign tumor arising from the bone. But if you just look at his scan, then there's expansion of the medullary cavity, and the maxillary sinus is completely obliterated on the other side, on the involved side. So we decided we'd go ahead with a biopsy, and when we did biopsy the bone and did special stains, we could pick up fungal filaments in this patient. So fungal disease need not present only as a soft tissue disease. You can have osteomyelitis of orbital bones, which typically presents with splaying of the bone or thickening of the bone on that side. And this is one more red flag that you should have in your mind. So she's been on treatment with antifungals. The nodules sort of reduce significantly, but the hypotropia persists. We've had to perform a tarsorrhaphy to keep her cornea protected. Yet another case, when you see this sort of a discharging fistula, think of either a dermoid or a fungal cellulitis. In this patient, along with the discharging fistula, we had the picture of ophthalmoplegia. You see a complete ptosis over there. There was no motility of the eyes. So you should start thinking that there's something in the orbit more on lines of fungal disease. If I were to show only the scan, then probably the first thought that would come on to anybody's mind would be that this is a mass lesion producing, some amount of bone destruction. It's in the lacrimal gland region. Probably this is something like an adenoid cystic carcinoma, which tends to show perineural spread and have some amount of skip lesion. But all of this was just pure fungal disease, which responded very well with intraorbital injections of voriconazole. This was aspergillosis. Now, this is one picture. It's very old. This is, I think, is 2002. You can read on the scan over here. But just to tell you that fungal disease has always been there. It's not that mucormycosis is something that we're seeing only now. This was a patient with fungal disease and absolutely no sinus involvement. It's just apical involvement, for which quite frequently we tend to start steroids, assuming that this is Tolosa Hunt. And starting steroids in these kind of patients would be devastating. So it's always good to get some tissue for biopsy. In this particular patient, an endonasal biopsy was done. Tissue was procured from the apex without affecting the optic nerve and the vision. And this turned out as a fungal disease, and he was treated with antifungals. So just to conclude, whenever you see an immunocompromised patient with signs of ophthalmoplegia or some discharging sinuses or bony lesions, such as destruction of bone or hyperostosis of bone, suspect a fungal etiology and perform a workup accordingly. Thank you so much.